So as we were saying, so 1,200 kids aged 4 to 14. Basically, the 14-year-olds are kids who are exposed to that special period back in the 90s. So increased morbidity and mortality from infectious disease, low nutrition, low access to medical care, versus kids who are 4, or 5 or 6 who were not exposed to that period. For those of you who don't know, Cuba has more physicians per capita than any place else in the world, including the United States. So they have access to a lot of medical care. And so what I want to look at here is the percentage of positives. These are kids with atopic disease. And as someone pointed out, it's pretty robust. I think it's right here. So basically, black means that you're going to be a younger kid. So that's part of one problem, confounder here. But you're younger, but you were not exposed to that special period in Cuba in the 90s. But as you go back farther, so here's kids exposed just during infancy, and here's kids exposed during infancy and early childhood. So kids born, really early in that special period. And, the point here is in this ecological study, understanding the caveats with that type of study, is that there appears to be sort of a dose-response relationship between your exposure to this general breakdown in society, increased morbidity and mortality of infectious diseases and low nutrition, and the development of atopic disease. So we went from sort of a very basic study in science, looking at, your microbiota on your skin, to sort of the big picture, your basic exposure at a country level and development of atopic disease. So complicated. So here's another study. I mentioned that there's, in that hygiene hypothesis, that there's conflicting data between bacteria exposure and viral exposures in the development of disease. This is a really nice study published in Chest just last year of a longitudinal study over 37 years. So that's a ton of data, very long term. It was done in Tasmania. And basically they recorded in these kids, or these adults now, pneumonia, history by parents. So they just asked the parents, did the kids ever have pneumonia? And then school records looking at very specific select group of diseases: measles, mumps, rubella, zoster, diphtheria, and pertussis. Because those are ones that would be, can be tested for and would be recorded. So nothing else. And they basically, their basic summary results was that infectious diseases in childhood protect against persisting asthma in later life. And persisting, it's a little hard to read here, is the presence, just so there's definitions, the presence of asthma or wheezing ever by the age of 7, together with an attack in the previous 2 years at each subsequent survey age. So they follow these folks over 37 years, right? Some of them are kind of about 40 years old. And so they had to have asthma when they were a kid, and they would have to have asthma at each survey time, at least sometime in the prior 2 years. So persisting asthma through the course of their life. And that pertussis, measles was associated with new onset asthma after childhood. So again, sort of conflicting data. Some exposures appeared to protect, but some exposures in this particular were, especially pertussis and measles, was associated with new onset asthma, but when they were later on as adults. And so the authors sort of hypothesized that better vaccination and protection for pertussis and measles would be protective against adult onset asthma. And basically, it's a little, their analysis, again, I'm not a biostatistician, but when you look at each disease, so here's just one infectious disease being any of these, 2, 3, 4, each single one at age 13, 32, or age 44 with persisting asthma, the association, you can see all of these cross 1. So not any one of them is associated with the development of asthma as an adult or at any time period, but the trends over time are what are significant. So this bottom one, right here, so going down at age 13, age 32, age 44, all the trends meet statistical significance for exposure of having had any of these diseases, 1, 2, 3, or 4, and the development of asthma in each of those time periods.
Development or reduction of development?
Reduction in development.
Do any of these studies address sort of the difference between natural immune response to an infectious disease and immunization?
So nothing that I reviewed looked at immunization. So their hypothesis being immunization against pertussis and measles, preventing the disease, sort of a two-step process. Immunization followed by exposure, I guess, and not developing disease. So I don't have.
I seem to remember a couple things in the 90s where they were looking at that, and obviously you make immunoglobulin responses, but the sort of Th1 response is much more vigorous when you get the actual disease, which would have more of an effect on atopy.
No, it's an interesting question, yeah. So a different immunological profile based on natural infection versus vaccination. Because vaccination is not perfect, obviously, right? They only get one or two antigens. Okay, so this is sort of getting to, I think, your question about this link between having bacteria present, it's maybe not pathogenic bacteria, and the development of disease. So these folks, this is a paper just published in Current Opinion Allergy and Clinical Immunology looking at basophil activation. These guys seem to think that they've hooked on to what's a really core issue here. And what they basically did, this is all in vitro, it's not in people, but they wanted to look at basophil activation. And they wanted to do it, they basically did it with bacteria, with an allergen, and then in combination. And what they called it suboptimal dosage. So not disease-causing exposure to bacteria or symptom-causing levels of the allergen. But so if I just walk through this here. So basically they looked at, on flow cytometry. Is everyone comfortable looking at flow cytometry? So I'll try to walk through a little bit. So basically they took cells, right, and they separated them by this CD marker and size. So these are the basophils here. So they boxed on that. And then this is basically the negative control looking at specific markers for basophils. And so an activation of basophils. So up here would be activated basophils. So you can see only 2% of this population is activated. 2%, that's the negative control, so that makes sense. Here's stimulated basophils, right? So they basically move up on this axis and this axis. And you can see that out of the whole population, 74% become activated. CD63 positive. And then they walked over here, and basically this is exposure to suboptimal amount of allergen, in this case D1, and they looked at activation about 28%. So this keeps disappearing. So they get about 20% with just exposure to the allergen. And when they add E. coli, they get about a 9% response, so activation of basophils. But when they mix both of them together in vitro, so they take a small dose of allergen, they take a small dose of the E. coli, and mix them together, you get basically a twofold increase in the activation of basophils. And so, and I have to look quickly at my notes to make sure I'm saying this right because I'm not a basophil expert. What they basically said is that activation of basophils by cross-linking of the allergen to specific IgE by surface Fc epsilon receptors is potentiated by the presence of bacteria. Now, they don't have the basic science of why that happens, but this is a basic first step in looking at the basophils, which are fully capable of being, if you activate them by themselves, are fully capable of producing the allergic response. Appears to be, this is driven by that two pieces, the allergen and the bacteria, and the idea of potentiation. Does that make sense? So this is not in vivo, this is just in the dish.
Isn't there's a report about E. coli flagellar antigen also potentiating dust mite allergy in the same
right. And
as an adjuvant sort of effect?
And I think that's those observations that have led to these experiments. Yeah. And this is probably the very basic science first step in looking at what is happening at the cellular level with that exposure. So there's something E. coli in the presence of these allergens that are causing this potentiated response in the cell line that drives allergic responses, or is fully capable of driving allergic responses. Does that make sense? Again, I'm not a basic scientist in this realm. I'm just reviewing this for you.
None of us are.
Basic scientists are safe.
Yeah, so I can hear them talking over there. So you think it's a toll-like receptor?
Yeah, it's probably a toll-like receptor, some innate immune response to the E. coli.
But at the same time, so TLR activation with the IgE receptor,
innate and adaptive at the same time.
all at the same time, causing this. So please, you guys, please comment.
Quiet.
Yeah, I'm very clear. I'm not an expert in these things. I've done lots of flow, but not in basophils, and certainly not in the allergic responses. So am I making sense in the way I'm explaining this at all? Basically, the takeaway point is that if you have both elements in a potentially infectious disease or a bacteria and an allergen, you seem to have potentiation of the response, of the potential allergic response. Is that right? You guys agree with that? So, again, some key points. Asthma exacerbations. So this particular group, this basophil group, this is what they say. Strictly related to infections. In the past, viruses were considered the main infectious agents, whereas present basically bacteria seem to be involved. From an experimental point of view, the presence of the suboptimal dose of bacteria in culture are able to induce activation of basophils, but only when there's allergen around. So that's kind of important too. It's not just the bug. You need to have the allergen in order to get the potentiation. And then activated basophils have the capacity of secreting all the mediators of allergy in the environment. So basically all the cytokines you need to get the allergic response in a patient. And these laboratory evidence are sort of a first step in actually linking those two things together. I'm sure there's other data out there, but these guys, this is what they said. I thought that was a pretty nice paper. Usually you don't get data that's that clean. At least in my experience. Maybe just me as a laboratorian. Okay, so, not all allergic response, I guess, is allergic response. So here's moving things a little bit towards the infectious disease side. So this is a series of 33 kids diagnosed with persistent wheezing resistant to systemic steroid therapy, so corticosteroid therapy. And basically, kids with this sort of persistent wheezing syndrome, they have a lot of morbidity, they get lots of resources, they get lots of corticosteroids, they probably get lots of treatment with antibiotics until they get sort of diagnosed. And basically, they took 33 kids in this study, I think this was in Germany, and they all went through the whole workup. They got worked up for reflux disease, they got worked up for all the other stuff. They had reflux, they got treated, but they still had persistent wheezing. And they underwent bronchoalveolar lavage. Sorry, again, these are out of order, guys. Again, I added notes, so these are a little bit cleaner. Drew will send out the new ones. Basically, they had all under BAL, and they said, so they broncho these kids under strict, sterile conditions you can, sticking a tube through someone's mouth into their lungs. And they said anybody who had 10 to the fourth or greater colony-forming units per mil was diagnosed as having a bacterial infection in their lungs. And this is, they pointed out, higher than the quantitative criteria for like a pneumonia in an adult, which in their group would say is 10 to the third. So they went a whole log higher just to increase the specificity. And so when they brought these kids, they looked at anybody who met those criteria, greater than 10 to the fourth bacteria in their lungs. And the kids who had positive cultures who met that criteria also appeared on pathology to have increased neutrophilic inflammation. So they had both a bacteria at a high concentration and they had a neutrophilic response, so an immunological response in that setting. And here's basically what they saw. So here's, you can look at monoculture co-infection, but probably just to get the idea here, this is the total. So out of the 33 kids, about half had a positive BAL, had a culture that met the criteria for infection. Most of them had H. flu. A lot of this was non-typable H. flu. Then the next one down was strep pneumo and Moraxella catarrhalis, which are all known pathogens in the respiratory system. Here's viral infection, which actually there's it's 21%, 7 out of 32 had RSV. You can see they're sort of scattered around here, but no viral infection, about 78% versus 48% up here. And then there's one kid with Mycoplasma Pneumoniae, again, a known pathogenic bacteria here. But basically, the idea here is that these are kids with persistent wheezing who had done the whole workup, who actually, these guys would say that actually had an infection that was chronic over time, causing their symptoms. They had both a pus in their lungs, they had bacteria in their lungs, they had symptoms who were not responding to corticosteroids or standard treatment for wheezing. And so, what to do about them isn't entirely clear either, because they didn't have good data. They didn't present much data on what happens when you treat these kids with infection. It was what I basically gleaned from the article was that they don't seem to respond to antibiotics very well either. So what to do about them isn't clear. But it's also seems from this saying it's not purely immunologic response. It's not necessarily an allergic condition. And I'm not sure if other people have experience with this.
I'm just wondering, from an ID point of view, do you buy that you have kids who have bacterial infection in their lungs that don't present clinically with pneumonia?
Yeah, and so, I guess the pathology associated with infections is varied. and whether there's deficits. I mean, we just looked at 200 people to start off this talk who had this weird autoantibody response, and whether these kids have an abnormal response to infection would be an interesting question for me. I mean, why do they not have, a big, they have some pus, but they don't have like a lot of pus, which is what you see in pneumonia. And so, there's something else going on here that I think hasn't been defined. Why they're not clearing these bacteria, right? So it seems like this is causing a disease, but the problem may not be the infection. The problem may be the response to infection.
Well, this is analogous to Bisgard's work, where he did those hypopharyngeal samples and found there, in neonates, and found there's relationships between the presence of bacteria and, later on phenotypes. But if you treat them, it doesn't really make a difference.
Right, and that's what I think. That's what I basically glean from this is treating them doesn't do anything either. So I don't know. Maybe these kids aren't capable of clearing these bacteria.
What do they show on a chest X-ray or high-res CT?
I think these kids don't have any evidence of the
So on even high-res CT, they don't have any evidence?
I don't think these kids, part of the workup, got a high-res CT, but they didn't say explicitly they didn't get it. But they went through the entire workup, the standard workup in Germany, high-quality medical system for persistent wheezing. And these are kids who have been wheezing for a long time.
They look at the type of white cells in the BAL.
Mostly polys, so
yeah,
neutrophils.
not the EOs.
Nope. Yeah, that's a good question. So again, I would say we're this type of disease appears to be somewhere on the continuum. And the reason I like doing this talk is there's a continuum between the immunologic allergic part and the infectious part, right? There's not a hard and fast line between these problems. What you guys see and what I see are probably a lot closer together than we traditionally think, right? It's really a continuum between the disease processes. So what do you do about it? So maybe this paper would say, get those kids a dog. Right? So this is a paper on pediatrics just last year as well. And so I just have to ask, so you guys are all allergy immunologists. How many of you have a cat or a dog at home? So a little bit over half. Okay, just curious. I have chickens and frogs.
In the house?
Not in the house, yes. But it doesn't really necessarily matter that much, right? So basically, they looked at this is percentage of healthy weeks, and so healthy weeks was no antibiotics, parents saying they're healthy, basically doing well, little kids on a diary. And so this is percentage of healthy weeks. So like 63% with a dog, 65% with a cat. Without anything, right? And this is none or not inside. And then this is dog or cat, less than 6 hours inside, 6 to 16 hours inside, greater than 16 hours inside. And basically looking at the difference between having an animal in your house and percentage of healthy weeks for a kid. These are little kids, not adults. And these are all statistically significant differences. I would say clinically, are they big differences? 65 versus 72%? Not a big difference. Is this the intervention, a dose of a dog for your kid? But there appears to be a signal there between these groups, between having animals inside, outside, versus having none, and healthiness. And healthiness, as I say, one of the particular things here, which is a theme we're going to continue on as well, is exposure to antibiotics. Because little kids get antibiotics like you wouldn't believe, right? And we know, I was trying to find the actual data last night, but I've seen 2 papers in the last couple of years looking at the disturbance in the microbiota in children exposed to antibiotics. And I might have even talked about it last year, maybe, for otitis. So on average, it's an incredible, it might even be a majority of kids in the first year of life get antibiotics for otitis media, right? And if you look at their microbiota, their gut microbiota, it's disturbed for months. And then a lot of those kids, probably majority of the majority, get a second dose sometime in the second year. And the disturbance in their microbiota, which we know is linked to their development, to their immunological development, and probably, allergic disease, I hate to be, is disturbed for like another 11 to 12 months. And again, scientists over there may remember this better than I do, but the microbiota disturbance goes on for over a year, right? In the critical time of their life when they're developing their immune system. So, a big deal.
Are these people in this study, these children, healthy children?
Yeah, these are all healthy kids. These aren't kids with allergies. Basically, they looked at how much of the time was the kid healthy by the parents' assessment. How many of the kids got? This is sort of a group of things. How many times did you get antibiotics? You know, it was a group measurement. So basically, overall healthiness. So you're a little bit healthier. Your kids were a little bit healthier, got less antibiotics if you had an animal in the house, particularly a dog or a cat. I'm waiting for the chicken study to come. And the frogs. I won't let my kids touch the frogs.
The warts.
Salmonella.
Yeah.
Hedgehogs.
Hedgehogs are very good. We're actually waiting for, we have a friend whose dog they're breeding, so we're waiting for that. Moving to something a little bit different. And and again, this is something you guys are maybe way more familiar with. Is this idea, there's this sort of push by immunological societies about recognizing primary immunodeficiency. And this is kind of a big push by the societies, I think. This goes back to 2011. But basically, they wanted people to be aware of the risk for primary immunodeficiency, recognizing those kids or those patients, and get into the right care pretty quickly. And so they developed these 10 warning signs of primary immunodeficiency. You can see it's greater than 4 ear infections, sinus infections, pneumonias, recurrent deep skin or organ abscesses, persistent thrush in the mouth or fungal infections, deep-seated infections, including septicemia, antibiotics, greater than 2 months antibiotics with little effect, need for intravenous antibiotics to clear infections, which that doesn't work for me because that's like 3/4 of my patients. Failure of an infant to gain weight or grow normally, family history of primary deficiency. Basically, they went back and looked at these. This is sort of a public health effort to recognize folks with this, and looked at whether you have less than 2 warning signs, greater than 2 warning signs, the relative risk. And basically, for some of these, there was a small increase. You can see this one doesn't cross 1, that one doesn't cross 1, but the rest of them do. So if you had a neutrophil PID or any PID, and this included everything, Wiscott, Aldrich, SCID, and everything, there was some benefit to recognize things, but having greater than 2 warning signs, because obviously if you have just 1 or 2, it's not going to get you very far. You know, if you had this one and greater than 2 infections or greater than 4 infections, that's not going to be a very specific marker, sensitive marker for primary care providers. So basically, what they showed in their paper is that this isn't the important thing. Isn't everyone getting screened with these things. One is awareness. And what they really pushed was this family history of primary immunodeficiency as being the most important thing. Is that when a kid comes into care or an adult comes into care, does anyone in your family, mother, dad, brother, sister, have any history of immunodeficiency or problem with infections? As being probably the most important thing, because this is not getting out to primary care docs. And if it does get out, it's not being done very much. And when you do it, it's not very predictive. So what they're kind of trying to push is a shift towards recognizing family history, right, and getting those people into care normally. Which I think this whole thing was kind of interesting to me because, when I see folks in my clinic with persisting Staph aureus infections, they often come in, or other, recurrent infections, skin and soft tissue infections, they come in looking for some diagnosis of why is it happening to them. And, as an infectious disease doc at a tertiary care hospital, I do sort of a basic immunological workup for adult onset immunodeficiencies. And over the years of my practice, except for Monomac, I've had none. So the sensitivity of this is quite low.
Can I ask what you and your colleagues do in terms of that first line screen?
Yeah, it's probably, I'm embarrassed probably, because it's probably terrible, but we look for neutrophil burst assay for chronic granulomatous disease, because you get that in your kind of early 20s as a presentation. It can be sort of subtle. We look at immunoglobulin levels, so hyper IgA is a common disease. We tend to look at T cell markers, especially now that I've had this Monomac guy coming in weird. We obviously do HIV testing on I do HIV testing on every single patient I see, no matter what, in or outpatient. And I would say at Harborview, that's where we stop. At the U, there's a couple of folks there, so Bill Barrington, when Conrad Lyles was there, and then I think there's another guy who just left for Stanford, Paul Boyke, who I think probably when they get referred patients to a bigger, larger panel, when I send people to Hans, Ox, by the time I get to that, if say everything's negative, I'm like, there's something's weird going on. I send to Hans, and I've still had no positive hits except for the Monomac, which we diagnosed at Harborview.
I mean, it's great that people are thinking about this, but sometimes I'll see patients who've had an IgG subclass panel, and that was the entire immune screen.
Right.
And they were told by that, clearly not an immunologist, but told that I'm fine. I had normal IgG levels, or sometimes I have an IgG subclass deficiency, and that was the whole diagnosis, but in fact it was part of a much higher order problem. So I was sort of curious what you guys were doing.
Does what I say make sense, or is it not? I mean, I tried to do basic screening, and I've only referred people out to an immunologist a few times. But again, I haven't had high. And again, on my population that I deal with, I got tons of people with advanced antibiotics to declare infections because they got freaking horrendous infections. But it has nothing to do with at least an identified immunodeficiency. It usually has to do because they had their tibia dragged across the highway or something.
I think part of the problem is this panel that we've all been taught, and the fellows could talk more about this, we completely missed the abnormalities of the innate immune system.
Yeah.
And I think that whole percentage is how we factor these things out. It's going to change dramatically as we start to have routine tests for all those.
I think like the TLR stuff you talked about, I know in an ID group like Tom Holland's work and TB and stuff like that, I mean, I think TLR is going to be a huge part of this going forward. There's going to be basic testing for that. I mean, this whole idea of whatever we're going to call it, personalized medicine, individualized medicine, genomic medicine, you don't understand, because there's clearly why some people progress with an infection and other people don't. I think people are just trying to get it.
And I'm convinced that Staph aureus has got to be a host response, because I think from the ID side you talk about, I'm thinking like say MRSA, it's the virulence of the organism or the strain or whatnot, but there's also that host response. I'm sure there's a TLR, some sort of an innate response, because you see those kids, I train in pediatrics, you see those kids who have constant, virulent abscesses over and over and over, and no one else in the family is even colonized or
Absolutely.
infected.
I think you're absolutely right. There's something, if you look at just the colonization rate of Staph aureus, I mean, there's coevolution between Staph aureus and humanity, and there's receptors in the nasal epithelium for Staph aureus that some of us have, some of us don't. And, why? There's clearly something going on. I think you're absolutely right. I think for us, when we're seeing patients, in ID clinic who have these problems, and probably you too, it's a struggle, because people really want some explanation, some way out. And I don't have an answer. But I think you're absolutely right. And they don't like it's your host response, right? It's part of your immune system. Okay, so I had to talk about this. So I don't know what you guys feel about IDSA, but I'm a member of the Infectious Society of America, and they just came out with the IDSA clinical practice guidelines for acute bacterial rhinosinusitis in children and adults. And from what I talk to primary care docs, this is a big help for them. So guidelines, as everyone knows, are mostly expert opinion rather than science. If you look at these, and a lot of the people who sit on the boards tend to be involved with drug companies and things like that. I think IDSA of all the societies tends to be on the lower end of that, but the expert opinion still plays a large role. So with that caveat, primary care docs really like guidelines, right? Because it provides them with some support when they're talking to their patients, particularly when they're going to say no antibiotics. And again, this is sort of a thematic element. And do you want me to stop at 8? Because I can stop at 8. I know.
If you can stay, whoever wants to stay will.
Okay.
So we gave you a hard assignment today.
Finish this one at least.
Yeah.
Okay.
This one kills us.
This one's
Nice.
So the first thing is if you don't know what's out there, it's out there. So it's freely available, idsociety.org. You just Google ID Society, sinusitis. The guidelines are out there. They just came out like in the fall. And this helps provide information. And so here's the pathway. So first, as you guys just said, it's kills you. So, 13.5% of all adults have had sinusitis, at least a diagnosis of sinusitis in the last 12 months. That's 20 million visits a year. About 1 out of 5 antibiotic prescriptions are for sinusitis. For diseases usually caused by viral upper respiratory tract infection. So bacterial infection tends to be a complication. It happens somewhere between 0.5 and 2% of the time based on data. A very difficult gold standard to diagnose most. If you look at sinusitis studies, they're basically, when you actually look for bacteria, it's someone who's getting, a rod jammed up their nose to sample it, not a swab or something. It's usually, so by the time they get to an ENT or someone who can actually, and do you guys do those?
We don't usually culture.
Yeah, so, but, when they get to a person who's going to do a procedure, right, it's a select population. So there's not good studies of people presenting with just plain old first-time acute rhinosinusitis who have, scope stuck up their sinus, right? So but of the ones that's thought to be 0.5 to 2%. And again, I kind of talked about this, a couple of themes. One is this continuum between immunology, allergy, and infectious disease. But also this problem is that when you have allergic, immunologic, and infectious diseases, a lot of antibiotics get thrown at them. And then you have, and actually the second half of the talk, which we won't get to today, is the problem of antibiotic overuse, which is enormous. And it involves everyone here. So leads to complications and a lot of resistance. So here's the breakdown. I try to get the cleanest one here. So basically what they wanted to say is signs and symptoms, persistent or non-improving. This is 10 days, so a week and a half. Severe for less than a week, 3 to 4 days, and worsening or double sickening in greater than 3 to 4 days. So someone who gets sick and then it gets worse after that. And then they break it down by risk for resistance, and that's listed over here. So little kids under 2, over 65, you're in daycare, which is everyone. Work is just daycare for adults, right? So prior antibiotics within the last month, prior hospitalization the last 5 days, comorbidities, immunocompromised. So let's say risk resistance, no, which I think is most people. No. And so if you meet these criteria, you go on to initiate first-line antimicrobial therapy. And what they say is amoxicillin clavulanate, not amoxicillin, not doxy, amoxiclav as the way to go. First-line drug. If the person's allergic, has a serious allergy response to penicillins or amoxicillin, then levofloxacin would be the next drug there. And then they look for improvement, and you complete 5 to 7 days. Worsening, broaden coverage, or switch to a different antimicrobial class, and then worsening improvement. Complete 5 to 7 days in antimicrobial therapy. So, and then down here, worsening or no improvement after 3 to 5 days, this is imaging and sinus or meadow cultures for pathogen-specific therapy. So, again, this is probably not provide new information for you. You guys know this. But this provides sort of a high-level guideline that's as evidence-based as it can be. It is not 100% evidence-based, but it's as evidence-based as it can be. As I tell people, is that, it's much better to be somewhere, all of us doing the same thing, because there's a true way to do this, right? There's a true way to treat each patient. We don't know what that true way is all the time, but if we all start acting in the same way and practice the same way, we can at least figure out how far we are away from truth, right? Rather than all over the place, where we're all doing different things. So if we all sort of kind of try to move towards one, albeit right or wrong, way to treat patients, we can start figuring out what's going on. Plus, sinus disease is painful, uncomfortable, it causes morbidity, but it generally doesn't progress to something horrible, sort of like UTIs. It's uncomfortable for the patient, but we have time to think through it. And the big thing in our medical culture is this part. And maybe all you guys are creative, because I'm sure you are, but a lot of my colleagues, including myself, aren't, is that it's calling the patient after 3 to 5 days and saying, how's things going? Is that antibiotic working? Or are you feeling worse? That second sort of visit or phone call is really key for a lot of these disease processes. So it's there, look it up. You can bring it out, show patients, hey, this is what we are doing. And that sort of provides some backup and confidence when you're talking to patients for a disease that's hugely prevalent and as a major utilizer of antibiotics.
And do you use any milligram per kilogram for the dose of augmentin? Because
no, so there is data there. There is a recommendation for normal dose or standard dosing of amoxiclav and high dose amoxiclav. And I'm trying to remember the paragraph. I actually reread it last night. There is a comment specifically on that question, and I'm trying to remember. I don't remember exactly what it said. It's when to use it or when not to use it. But they do comment on that specifically, on high dose amoxiclav. That's the only place I saw in the whole guidelines.
Well, the last time I saw it addressed was they were trying to get us to treat intermediate resistance with high dose amoxicillin versus another line drug.
When you say intermediate resistance to a pathogen culture?
To basic, yeah. And they recommended 60 milligrams per kilogram of the amoxicillin component, and I've never seen anything change from that.
Again, I'd have to go back and look at that specific. There is a comment in that, but I don't remember. I don't want to say in front of everyone it would be wrong.
Well,
So
the only problem is if we use that caveat, then everybody gets 2,000 milligrams of
yeah, I would say if you think that there's resistance, intermediate resistance, I don't know what that really means. So the two defining bodies, and this is what I talked about last year. You guys, for some reason, really liked the CLSI in the United States, UCAS in Europe. UCAS doesn't use intermediate at all. There's sensitive and resistant. The United States has this weird nebulous category, intermediate. And I would say that intermediate, I'm more of a UCAS person, I'd say intermediate is resistant. And so I would just go to a different drug. There is probably some data about higher dosing for quote-unquote resistant organisms, whether the person can tolerate that higher dose, and whether you can get higher doses in the serum is a question. So I don't know the answer to that with amoxiclav. I would just switch to a different drug that's sensitive.
Assuming you have a culture.
Yeah.
If you have a culture. Now, again, what does that culture mean?
You're
You know, if you just swab the meatus, and again, I did a review of a paper on chronic rhinosinusitis, and again, it's a very, you know, the data comes from very biased populations. It's from people with chronic or recurrent sinusitis, and it's from people who get, you know, a tube jammed up in their sinus. I mean, it's not these people. It's people who have a very specific, you know, morbidity associated with the disease. Okay, so that's all the sort of that stuff. But I do, if you want to stay, I'll just give you 1 minute on why antibiotics are a problem. So it's not just a hospitalized patient. So Joshua Liederberg, Nobel Prize winner, said this back in '58. He said, "Since pit against microbial genes, we have mainly our wits, and we as a society, as a population in the globe, haven't been using our wits very much when it comes to antimicrobials, because those guys know what they're doing, right? The bacteria know this already." So, quick case: 27-year-old man comes to your clinic with symptoms with urethritis, says you're active with men, oral anal sex, HIV negative. He gets a urine test for chlamydia and gonorrhea test, a nucleic acid amplification test, right? So that's cooking. So he's going to leave. So what are you going to do? Give him ceftriaxone, IM, azithro, cefixime, azithro, amoxiclav, penicillin. I'm not sure you guys have any.
We don't see
this very often.
So a year ago, you would have given him cefixime and azithro. Now you have to give him ceftriaxone,
part
IM.
of his therapy.
And gonorrhhea. So this is straightforward. This disease causes over 500,000 cases that we know about in the United States. For women particularly, it can be asymptomatic, or men and women can be asymptomatic, but women it can cause pelvic inflammatory disease, organ damage, infertility. Major cause of this problem across the world. It can be asymptomatic and carried. This is a great article by Jerome Grubman in the New Yorker. Made me very happy last fall to be able to read about gonorrhea in the New Yorker. But the big issue, I'm going to skip this part, is that drug-resistant gonorrhea is here. So this is a public report from just January 10th, talking about a study that came out of Toronto. So North America, looking at 133 people in a clinic who had gonorrhea resistant to cefixime. This is the most commonly prescribed and the recommended antibiotic for gonococcus. If you don't have cefixime, right, oral antibiotic, there's no oral antibiotics for this disease. It is intramuscular or intravenous. So this is a very common disease, large number, that is running out of antibiotics quickly. And if you look at cefixime resistance, here's 2006. Here's cefixime resistance, so basically picking an MIC associated with failure. 2006, 9, 10, 11. Very frightening curve, right? This is our go-to oral drug for this disease. It gets rid of gonorrhea in the throat, the rectum, and the urethra, and is no longer effective. When you get to about, WHO says about 5% resistance, you can't use that drug anymore. And what's also frightening, ceftriaxone, which is the next drug, it's probably the next one. And I'm not sure if I talked about it here, but so we've lost, over the course of the years, we've lost beta-lactams to this drug, we've lost tetracyclines to doxycycline, we've lost fluoroquinolones, which used to be recommended, even before fluoroquinolones were recommended for gonorrhea. Fluoroquinolone-resistant gonorrhea was diagnosed in Hawaii. We've lost the oral beta-lactams, Cefixime. People are looking at high-dose Cefixime for this, so whether you can tolerate much like double-dose Cefixime to get higher serum levels to overcome that resistance. Those studies are ongoing right now at Hopkins and at UW. Ceftriaxone, intramuscular, so this means someone has to get a shot, plus there's azithro for chlamydia. Japan and a couple other countries, that people who have come from Japan now have diagnosed sex workers and people who have engaged in sex work in Japan with ceftriaxone-resistant gonorrhea. Asymptomatic courage in the throat. The problem is in Neisseria, other species in gonorrhea are promiscuous. They swap resistance genes back and forth. You can get exposed to lots of antibiotics in the absence of gonorrhea, which causes selection on the Neisseria you have in your throat or other parts of your body. You get gonorrhea in Japan. There's a big oral sex worker industry. It's kind of been, from what I understand, it's sort of an accepted part of the society. And so you get sex workers with gonorrhea exposure in the throat, swapping genes back and forth between other Neisseria, and now they have ceftriaxone-resistant gonorrhea. And that's getting the population. And what happens in North America is it comes from Japan, Korea, and other parts of Asia, goes down across the Pacific to Hawaii, comes up California into Seattle. If you look at gonorrhea prevalence in the United States, Seattle is the hot spot. We have tons of it. And now I'm going from oral drugs to intramuscular. If I lose ceftriaxone, That's intravenous gentamicin, or like 7 to 10 days of antibiotics. And for a population that has a proportion of folks who have problems with drug adherence, having to give them drugs more than one day, right? Folks who are at risk for gonorrhea, there's a proportion of those people who are at risk for not really taking their medicines.
Yeah, like
right?
99%.
Well, there's a lot. And so when you start talking about intravenous therapy or 7 days or 10 days of therapy in order to extinguish disease that can be asymptomatic, easily transmissible, and causes a large problem for people like fertility problems, you're talking about a serious problem. So my point being is that all the other stuff I talked about with allergy and immunology and infectious diseases, the overlap and then the exposure to antibiotics, this is not a hospital-acquired ventilator-associated pneumonia, highly drug-resistant gram-negative pathogen. This is gonorrhea. Straight up, out there in the public, easily transmissible, with developing very high resistance in a very short amount of time. Every drug this bug's been exposed to since 1945, it's developed resistance to. Every single one. And it's happening again.
Have they given up using probenecid in these people to try and boost their levels even higher?
That's a good question. I don't know about any data about using probenecid in these folks. That's a good question.
How about a vaccine for gonorrhea?
None that I know of.
No one's working on it, or?
I'm sure someone's working on it, but I don't know. The problem is who would you give it
That
to?
sounds like it.
I guess you would give it to,
Well, like they do
I can't
HPV
give
now.
HPV, but everyone gets HPV, right?
Right,
So
right.
not everyone gets gonorrhea. We have a tough time getting HPV into young girls, even though it prevents cancer, right? And if I said, oh, I'm going to give your daughter a vaccine against gonorrhea,
Just if you say you want to culture their daughter for gonorrhea, that just about gets you killed right there.
oh my God, yeah, exactly. That's a tricky thing. So I thank you for your attention. I can talk more if you want more, because I can talk about even more resistance. So this is the scary ones that are coming out. So this is a 21-year-old man doing missionary work in India for HIV orphans. Basically a perfect kid who's walking across a train yard, gets hit by a train, rips off his right leg, spends a week in an Indian hospital, comes to Harborview, up on the wards, just hanging out, getting care. He's got a couple drains in there. They culture the stuff coming out of the drains in his legs. And he had, I think, 5 different bacteria. Here's 2 representative gram-negative rods. Pseudomonas, E. coli. And remember I talked to you last year, I'm sure you guys remember it perfectly, talking about drug resistance. And as far as I'm concerned, I means R.
Yeah.
And colistin, which is, for those of you who practiced in the 60s and 70s probably remember, is coming back because it's basically a detergent. We have very little resistance. But I can't get 4 micrograms per mil serum concentrations of colistin. So basically, kind of close to resistant. This one okay. He also had, I think, VRE and other things. And so this is Nudeli metallo-beta-lactamase resistance, this is the first described case in Washington State. He was up on our wards just hanging out with this incredibly drug-resistant pathogens in his wound, draining, with a patient sitting next to him. Right? As soon as I heard about this, Doug Smith called me on babysitter. I said, Doug, if he's okay, please go to the room to let anyone in or out. We put him in containment right away because anybody who practiced at Harborview back in the early 2000s remembers drug-resistant Acinetobacter going through our ICUs and killing about 130 people because we couldn't treat it. So over the course of years, obviously, but this we were really worried about. So this was described just in 2009. It was people coming from India, going to Sweden, coming from India, going to UK, almost complete beta-lactam resistant aminoglycosides, fluoroquinolones, tigecycline, colistin. It swaps between a bunch of gram-negative rods. It's been seen in about 53 countries now. It's everywhere. And the big issue here, again, I talked to you about gonorrhea and why we have drug resistance. But so that's just talking about sort of individual prescribers. But here's India, 2005, 2009. India is an emerging economy, right? It has a huge healthcare system. And they are using antibiotics, just like we do. They started at lower, and now they're going up. And so if you just look at all the different antibiotics, in a short period of time, 4 years, this is antibiotic sales in tens of thousands of rupees. It is skyrocketing. Huge amounts of antibiotics. And what's the major difference between India, which is actually very similar to many countries in the world, and the United States when it comes to antibiotics?
Over the counter?
Right. What's that?
They're over the counter.
They're over the counter. There's no prescription. So even here, where we have to prescribe them, we're not using them in the best way possible. There, you just go to the pharmacist and say, I have an earache, or I have a cough, or I have tuberculosis, right? And you get an antibiotic. And, when you have tons of antibiotics used in a country like India is just representative because it's so big, such a large population. This is why you have new emerging infectious diseases coming out of there, with emerging infectious diseases being drug resistance. And so the group that did this, who published this paper, the first paper, Tim Walsh from Wales, who published the 2009 paper, actually India banned him. They said, you can't come back here, this is not true. So he actually had a bunch of people posed as journalists go and collect water samples from metropolitan areas, and they found that something like 30 to 40% of the water samples contained this drug resistance mechanism, NDM1, in the water. Because it doesn't appear to be increased pathogenicity at all. It doesn't make it a more virulent bug. It makes it just extremely hard to treat. So it doesn't make you sicker. This kid didn't have like a big whopping infection. I mean, he had an infection, but it wasn't going to kill him. It did take me 6 months to cure him. 3 surgeries, 1 bout of renal failure, 1 bout of neutropenia, nausea and vomiting, 30 pounds weight loss to clear him. And I mean, he was exposed to antibiotics for 4 months. Basically, I would treat him with quadruple therapy antibiotics until he could not tolerate it. So meropenem, colistin, rifampin, and tigecycline. I just stopped each drug as he started. He couldn't barf anymore. His kidneys couldn't handle anymore. His white count started dropping.
What's the antimicrobial we used to use in the 60s that rarely caused aplastic anemia? Chloramphenicol. Is that making a comeback?
So yeah, actually, chloramphenicol has been used in much of the world since then. And I think I haven't seen the data on this, but there appears to be differences between the rate of aplastic anemia with oral versus intravenous.
It was never very high in the first place, but it got basically condemned because of like 1 in 50,000.
I wouldn't be surprised at all if I've been waiting to use it. I wouldn't be surprised if we.
Mark Turk taught me to use it 40 years ago.
We're still using that. We're still using that.
Have you used it in Israel?
Yes, but ESBL bacteria can't use it for the ESBL. It's not effective for the extra drug, XDR or the ESBL.
Yeah. So I think it's being used in much of the world, but standard. But I think it probably be making a reintroduction. The big problem we face now is new antibiotics. We don't get new antibiotics. Right? We have just a couple, ceftaroline. In the past couple of years, there's a new TB drug for the first time in 40 years. 1971, rifampin, bedaquiline was just approved January this year. And we've had a few new antifungals. But since daptomycin, nothing new. Daptomycin was there before I became a fellow, so not a lot out there. So when we deal with these things, I'm dealing with drugs that we've been using for a long time in combination to treat them. And this is just the first case of a big problem. So,
are those drugs including agricultural use in that?
No, I think these are not, and that's an excellent point. So, does anybody know how many millions of tons of antibiotics we use? It's about 3 million tons on humans. Anybody know how much we use on animals?
100 times that.
13 million tons. Yeah. So we use far more antibiotics in animals than we use in humans in the United States. And trying to get a handle on that is extremely hard. Very, very hard. Because they're used for 2 reasons. You know why antibiotics are used in humans? So they're growth promoters. Someone observed back in the 40s, basically, if you gave a cow antibiotics, they'd grow faster. And so, as a society, we're complicit in this. Anybody who eats meat, I think, including me, is complicit in this. We want inexpensive meat and access. But a big problem. And basically, if you give animals subtherapeutic doses of antibiotics in huge settings where they're basically defecating everywhere and making giant pools, you've been to a factory farm where you've driven through Ellensburg, you know that there's huge pools of stool that are just infested. You talk about delis, main streets, that's nothing compared to those giant sewage pools associated with factory farms. And you're basically putting everything together. Suboptimal doses of drugs, high population, no disease, mixing stool together. And if you look at farm workers who work in those settings, carriage or colonization with drug-resistant pathogens is definitely higher. And we are actually causing, if you look at, there's been outbreaks of MRSA in animals, in pigs, that have come from humans. So it goes both ways. So we're killing the pigs and they're killing us.
Do you think the community-acquired methicillin-resistant staph is from eating all these animals that have been treated with antibiotics? Because it's different.
Yeah, it is. It's
how to turn it off. I know how to turn it off. It's my son.
What did you say? I didn't hear a word.
No, so her question was, do we think the community-acquired MRSA came out of out of the agriculture. I haven't seen any data to that extent. There are specific agriculture-associated MRSAs, but appear to be different than the MRSAs you see, the community-acquired MRSA, the penton, valentine, leukocidin, and associated ones. And it's going to be harder and harder because they're all mixing together now. So again, I don't want to keep anyone, but we use a lot of antibiotics in this country. And I'll leave you with this slide, is that even in our own country, where we use too much everywhere, there's huge variation. Like, why in the world does West Virginia, Tennessee, Kentucky, Louisiana, and Alabama use twice as much antibiotics as we do? Why on average does every single person get an antibiotic in those areas, and only in half, which I think is 533 antibiotic prescriptions for 1,000 people in Alaska and Washington? Half. I mean, it's astounding.
Do you know the answer, or you just throw
I don't know
it
the
out?
answer. Why is there variation? My point being is that it's not practice adherence, guideline adherence. So use those guidelines. Thanks for your attention. Sorry for all the mix-ups today.
Well, I'm sorry, we gave you such a hard time.
In Spain, they have chlorine.
Primary care doctor, maybe that's just why I use it so much. I know that it's consumer demand. I think it is it's natural gas.
The problem is if you feel bad, do it. But the problem is that it'll come out. But hopefully the room. Yes, sir.
Yeah. Reviews from Illinois, but I don't do ID anymore, but I used to the year.
So I think Drew's going to have to come in on
Start with the new antiviral, so is it just, subtype specific, or you can just write it down?
Oh no, so there's definitely data on the response to specific subtypes. So, 1A being the RX, 3 being